Hi, my name is Mattias Larsson. I'm a physician at Family Medical Practice in Hanoi. I'm an associate professor and researcher at Karolinska Institutet in Stockholm, Sweden. And I've been working in Vietnam since 97, hence 24 years. I did my thesis on antibiotic use and resistance. And the last about 10 years, I've been working a lot with hospital-acquired infections and then colonization with Carbapenem Resistant Enterobacterieasae, which I will talk about in this presentation. So this presentation is based on several studies that has been done in hospitals in Vietnam. So these are two hospitals. The upper picture is the Vietnam National Children's Hospital in Hanoi. The picture under is the University Hospital in Ho Chi Minh City, and we also have some screening pictures and some selective agar there. Vietnam has been extraordinary when it comes to the COVID prevention. So far it's been about 8,000 cases and 50 people have died with COVID in Vietnam, with 100 million population. Reacted early with outbreak in Wuhan, closed the border, quarantined all people coming in, then the rest of the world. For all cases positive, there is contact tracing. All contacts is put in quarantine and follow up with testing. So they have at society level been extremely effective. However, we have been working in the hospitals where hospital-acquired infection is a huge problem, as we will see. If the same measures were applied, contact tracing as well as quarantine or cohorting patients, this could also be dealt with as successfully. Some years ago, 2012-2013, we did a study, point prevalence surveillance every month in 16 hospitals, 21 ICUs in Vietnam, from the north to the south, both in the big cities as Hanoi, Ho Chi Minh City and Da Nang, as well as in the provinces. In the ICUs, we had 5 hospitals that had pediatric ICUs. There were then about 1,400 pediatric cases. Of those, 33% had hospital-acquired infection. The most common was Klebsiella. 55% were Carbapenem resistant. And adult care, 3,300 patients in 14 hospitals. 30% had hospital-acquired infection. The most common etiology was Acinetobacter baumannii. 89% were Carbapenem resistant, as you can see here. So 55%, 89%. So then we could see this is a huge problem in Vietnam. There is a lot of patients that do have hospital-acquired infection with very resistant bacteria. So we wanted to understand a bit more about this. One study we did in the neonatal ICU in the large pediatric hospital in Hanoi. We then studied all patients that had culture-conferred hospital-acquired infection and were isolated. So it was in total 296 patients. So if they had hospital-acquired infection with Acinetobacter baumannii, Klebsiella or Pseudomonas, the case fatality rate, if they had sepsis or pneumonia, was more than half of the patients. More than half of the patients died, as you can see here, right? And it was then correlated to multiple antibiotic resistance. The more resistance, the higher mortality. That was very clear. However, in order to have hospital-acquired infection, you need to be colonized. That's a prerequisite, right? So, in order to be able to prevent it, we need to understand the colonization rates. So then we went further, and we worked in all of Vietnam. So this is a study based on 12 hospitals, and we did then fecal screening, and we swabbed it on selective agar, so we could then see whether there was any resistant bacteria growing. So this is, as you see here, these are Klebsiella, the green ones, that were resistant to all different kind of antibiotics, and this is E. coli resistant to all different antibiotics. We also collected data on the clinical data, so we could correlate then the clinical variables with the microbiological variables, right? And this is one hospitals that we studied. Half of the patients were colonized, and most commonly with Klebsiella E. coli. If we look at the 12 hospitals that we published then in Vietnam, we had a total of then 2,233 patients. Of these, 52%, 1,165 were colonized. So there were different type of wards. Neonatal ICU, 65% were CRE colonized. Pediatric ICU, 70%. In the wards, half of the patients were colonized. In the emergency room, 16%, which is quite high, possibly due to high prior antibiotic use. In the adult ICU, 60% were colonized, 35% in the ward, and 4% in the emergency rooms. In total, then, ICU 64%, wards 45%, 10% in the emergency rooms, so 52% were colonized of all the patients that we assessed. So where does this come from? Well, if we look in the hospitals, first day of admission, 13% were colonized with CRE. Then, if they were treated in hospitals for 2 weeks, 89%, almost 90% were colonized. So it's a lot of patients become colonized during hospital stay. So there's a high acquisition rate during the hospital stay. And what are the different risk factors for getting CRE colonization? In multivariate analysis, we see it's the treatment time, as we could see. That's important. Hospital-acquired infection and carbapenem use are also risk factors. These are patients that are isolated with Klebsiella pneumonia, the hospital-acquired infection in the neonatal ICU. So what we did, admission and discharge CRE screening study population of 329, also in the large pediatric hospital in Hanoi. At admission, 32% were colonized. They came in from the provinces to this large central ICU. So there is a lot of dissemination of then CRE also in the provinces, right? After an average of 8.1 days, 88% were colonized with CRE. So the acquisition rate was 84%. Most patients that were admitted also got colonized during the hospital stay. So this is a major problem. There is a huge dissemination and transmission of bacteria during the hospital stay. If we look at antibiotic resistance, then most of the bacteria were all 100% were resistant to cephalosporins, and of course then to carbapenems, because that was what we were screening for. Aminoglycosides, casein, gentamicin was very high, tobramycin as well, ciprofloxacin, levofloxacin. Colistin still susceptible. It's not a good drug, but it can be used in combination with others to enhance their activity. Cotrim, we still have some susceptibility for, which is good. This is a bit complicated table, but here is CRE at admission, right? Up there. These were those that are negative at admission, positive at admission. If they were negative at admission and they had a hospital-acquired infection, the mortality was 34%. If they didn't have a hospital-acquired infection, 18% mortality, right? So if they were positive, they were colonized, they had a hospital-acquired infection, mortality was 68%. And they didn't have it, it was 21%, meaning that it was twice the mortality if they were colonized. So it's a significant correlation between being colonized and mortality. The most common antibiotic resistance mechanism when we did whole genome sequence was KPC, MDM1, and MDM4. And we could see a shift from more KPC to more MDM1 and MDM4 with time. We did one study to try to decrease transmission in the large pediatric hospital in Hanoi, Vietnam National Children's Hospital. These are patients that are admitted, that are isolated with culture confirmed hospital-acquired infection with Klebsiella here and Pseudomonas there, right? In this study, all the patients were screened at admission. If they were CRE positive, they were reported as CRE positive. If they were negative, they were reported as negative. We did rescreening once per week. If they were positive, they went to the positive cohort, right? And we did discharge screening. And here, if they were negative, not colonized with CRE, they got the green sticker. If they were colonized, they got the orange sticker. At the baseline screening, where we did point prevalence for all the patients, then in the neonatal ICU, 78% were colonized. In the pediatric ICU, medical ICU, 84% were colonized. In the surgical ICU, 60% were colonized. In total, 76%. That means that most of the patients were actually colonized. So we had to cohort them to the positive, colonized positive cohort. So in total, when we started the study, we screened 948 patients in the 3 ICUs where we studied. The positive rate was 35%, slightly higher than in the neonatal ICU, what we had checked before, coming in from the provinces mainly. And then CRE negative was then 64%. We included 388 in the study. Some were excluded due to lack of clinical data, and also that they were discharged early or died early, so we couldn't rescreen them. 244 patients were rescreened at least twice, and then 61% had acquisition, meaning that they were colonized during hospital stay. 39% were not colonized during hospital stay. So the acquisition rate was a bit lower than we had before, which I would say due to the intervention with cohort care. There was then, when we looked at the data, a clear correlation between high incidence and so the hospital-acquired infection incidence was significantly higher among CRE positive. Also, high mortality was significantly higher among CRE positive. Hospital stay was significantly longer among CRE positive, and cost was significantly higher among CRE positive. These were the periods. So one period is approximately 1 week. First week after 8 weeks, and then we could see then that in the beginning the acquisition rate, meaning here you have the acquisition rate, and this is these are the different wards, and this is the average, right? So in the beginning, the acquisition rate first and second week was 71 and 90, and the last 2 weeks went down to 47, 48. So it was a decrease of about 45% in acquisition rate, which was very good, that we could achieve with cohorting the patients from the beginning of the study to the end of the study. And then we could see some in the univariate and multivariate analysis. Then we could see the different factors that were correlated to acquisition, which one, then the period, then the acquisition decreased during the periods if they had hospital-acquired infection. The cost decreased, and the hospital stay decreased also when we could decrease the acquisition rate. So in then conclusion, there is a high rate of CRE colonization in Vietnamese hospitals. There is about 30% CRE colonization among patients coming in from the provinces. And the central level hospitals, there is a high rate of acquisition. There is a significant relation between CRE colonization, hospital-acquired infection, duration of treatment, and crude mortality. Active admission, screening, cohort care of CRE colonized patients reduced transmission. We could see that hospital-acquired infection treatment type. Mortality we could not see, it was not significant, but costs. In central level hospital, active screening is cost effective. We don't know how it is in provincial level, depends on the province probably. So the cost effectiveness in provincial setting needs to be assessed. And active CRE screening cohort care can reduce acquisition of CRE and is recommended as tool for infection control monitor and basis for interventions. This is in collaboration then with different hospitals in Vietnam, Karolinska Institute, that also the training and the research academic collaboration between Sweden and Vietnam has been active in participating in these studies.